Okay. So, last lecture we had discussed about the different classification of gingival enlargement. Coming to the next classification, which is enlargement associated with systemic diseases. So there are many systemic diseases which have oral manifestations, and this is a two different mechanism. So these two different mechanisms are: first is when there is magnification of existing inflammation initiated by dental plaque, which is known as conditioned enlargement. Second is manifestation of the systemic disease independent of the inflammatory status of gingiva, and this group is described as systemic diseases causing gingival enlargement. So these two mechanisms are mainly responsible for the oral manifestations or for the changes which are taking place in the gingiva, which lead to increase in size of the gingiva or gingival overgrowth. Conditioned enlargement. Conditioned enlargement is the systemic condition of the patient which exaggerates the usual gingival response to dental plaque. Means the dental plaque, which is the local factor, which is the local factor for gingival inflammation, is already there, but the systemic condition of the patient is exaggerating the usual gingival response to dental plaque. So this will be termed as conditioned enlargement. And here bacterial plaque is necessary for its initiation. In this three main systemic diseases which contribute to gingival enlargement are present. First of all, hormonal conditions which include pregnancy and puberty. Second is nutritional, which is vitamin C deficiency, and third is non-specific conditioned enlargement. Enlargement in pregnancy. So in pregnancy, you will see enlargement which will involve marginal gingiva and generalized, or it can be single or multiple tumor-like masses. So here it can be localized or it can be generalized, or it may be a single or multiple tumor-like masses which are seen in pregnancy-induced gingival enlargement. What are the etiological factors? Main etiology is it is due to increase in progesterone and estrogen level, which is seen in pregnancy, and this lead to increase in vascular permeability and gingival edema. So main etiology is the presence or the increase in level of hormones which are responsible for the pregnancy. That is progesterone and estrogen, and it gets because of which vascular permeability is increased and gingival edema occurs. So in pregnancy, you will see marginal enlargement, which results from aggravation of previous inflammation. Second is tumor-like gingival enlargement, which is also known as pregnancy tumor. So pregnancy tumor, it is what it is. It is an inflammatory response to dental plaque. Means plaque is already there. Plaque is mainly present. Plaque is present for initiation, and the inflammatory response to bacterial plaque that is responsible for gingival enlargement. Clinical features: lesions are discrete, mushroom-like, flattened spherical masses. It can be sessile or it can have pedunculated base. Sessile means no base, whereas in pedunculated means it has a stalk which is connected to the base. Then it exhibits deep red pinpoint markings, and also painful ulcerations may occur. So these are the clinical features of pregnancy tumor, or you can say tumor like gingival enlargement in pregnancy, which is seen in pregnancy. Lesions are mainly discrete. The term mushroom like, this is the term which is used for pregnancy tumor. Flattened spherical masses. It can be sessile or pedunculated, and it also exhibits deep red pinpoint markings. Painful ulcerations may also occur. Histopathology of pregnancy tumor. There is a central mass of connective tissue. Neovascularization. Neovascularization. What do you mean by the term neovascularization? New vascularization means new blood vessels are formed, new arteries are formed. So this is lined by cuboidal endothelial cells. Varying degree of edema and chronic inflammatory infiltrate. And epithelium is thickened. Prominent retipegs are also found in the histopathology. So there are mainly four histopathological features. Central mass of connective tissue, new vascularization will take place, and you will see varying degree of edema and chronic inflammatory infiltrate, and epithelium is thickened, which has prominent retipegs. Now the treatment. What will be the treatment if a patient comes with a pregnancy tumor? How will you decide for the treatment? First of all, minimize the potential exaggerated inflammatory response related to hormone alteration. Then we'll go for the plaque control. Scaling and root planing should be non-emergent procedures performed. Long, stressful appointment and periodontal surgicals should be postponed until postpartum. So this is not at all carried out during pregnancy. We will be post this all these procedures should be postponed until postpartum. No medications and radiographs should be taken as the patient is having a pregnancy tumor. There is when there is marginal and interdental enlargement is there, so you'll go for the scaling and curettage. And if it is a tumor like enlargement, then you'll go for the surgical excision if possible. Then you can postpone it, otherwise you can do it at the time of second trimester, which is a safe period for treatment of the patient. Then enlargement and puberty. Enlargement and puberty, what are the clinical features? Clinical features includes marginal and interdental gingiva, often facial gingiva. It is associated with chronic gingival disease. It reduces after puberty. As soon as the puberty ends, it reduces after puberty. Capnocytophagous species and P. intermedia species are mainly found. These are the two main microorganisms which are found in the gingiva and which is causing enlargement and puberty. Histopathology, there is a chronic inflammation with edema, and treatment includes scaling, curettage, and oral hygiene instructions to the patient. Surgical removal may be performed in severe cases. If there is severe enlargement, if any severe enlargement is there, you can go for the surgical removal. Then comes enlargement in vitamin C deficiency. So what are the clinical features? This is also seen as marginal gingivitis, hemorrhage on slight provocation, and surface necrosis with pseudomembrane formation. So you will see here that there is marginal gingiva involved. In this marginal gingiva is involved, you can see marginal gingivitis. And if you do a slight provocation, you can see there is a hemorrhage, bleeding will occur, and also there is surface necrosis and there is a pseudomembrane formation in enlargement with vitamin C deficiency. Histopathology, you will see chronic inflammatory cellular infiltrate with superficial acute response, and there are scattered areas of hemorrhage, diffuse edema, collagen degeneration, and scarcity of collagen. So all these histopathological features are of vitamin C deficiency. Then comes plasma cell gingivitis. Plasma cell gingivitis is a typical gingivitis, or you can call it as plasma cell gingivostomatitis. What are the sites involved? Mainly marginal and attached gingiva. These two are involved in plasma cell gingivitis. Clinical features. Here you can see in the picture how plasma cell gingivitis is seen. It is seen as red, friable, and it bleeds easily. Side oral aspect of attached gingiva. Histopathology, epithelium shows spongiosis and infiltrated with chronic inflammatory cells. Lower spinous layer and basal layer usually gets damaged. and there are plasma cells infiltrate which are also seen. So plasma cell gingivitis is basically a hypersensitive reaction, and you are in that case you will see a red fibril lesion which will bleed easily, and it involves marginal and attached gingiva. Okay, now non-specific conditioned enlargement, which includes pyogenic granuloma. So non-specific condition enlargement, which includes pyogenic granuloma. What is pyogenic granuloma? It is a tumor-like gingival enlargement. Here you can see in the picture. See here, this is a tumor-like gingival enlargement, and it is a conditioned response to minor trauma. Slight minor trauma, if it is happening, there's a conditioned response to it, so which is termed as non-specific conditioned enlargement. Okay. So coming to the clinical features of pyogenic granuloma, this is seen as discrete spherical tumor-like mass. It is red, friable with ulceration and purulent exudation, involute to become fibroepithelial papilloma. So here you can see it is a discrete, means it is confined to a particular area of gingiva. Here you can see in the picture, it is a discrete tumor-like mass which is present between two teeth. It is red, friable with ulceration, and purulent exudation is also present. Histopathology, there is a chronic inflammation with granulation tissue, vascular spaces and epithelial atrophy is present. And in the treatment, what will you do for the treatment? You will go for the removal of lesion and local irritating factors. Coming to the systemic diseases causing gingival enlargement, it includes leukemia. So in leukemia, what will you see? How the gingiva appears? Let's discuss about it. Clinical features, you will see either diffuse or marginal, localized or generalized tumor-like mass in interproximal spaces. It is red, friable, firm and hemorrhagic. It is painful, necrotizing, ulcerative inflammation. So here you can see the picture, second picture. In this, you can see here how painful, necrotizing, ulcerative inflammation is there, which is present in leukemia-induced gingival enlargement. Histopathology, epithelium shows varying degree of leukocytic infiltration and edema, pseudomembranous meshwork of fibrins, necrotic epithelial cells, PMNs, and bacteria. Connective tissue shows infiltrated with a dense mass of immature and proliferating leukocytes, and also there are engorged capillaries which are present. So all these histopathological features are present in leukemia-induced gingival enlargement. Coming to the treatment part, in leukemic patients, first of all, what will you decide? You will refer the patient to physician. And prior to chemotherapy, a complete periodontal treatment plan should be prepared. What would be the treatment plan? First is monitor hematological lab values daily, administer antibiotics prior to any periodontal therapy, extract non-maintainable or potentially infectious teeth at least 10 days prior to initiation of chemotherapy. And thorough periodontal debridement is done and oral hygiene instructions are given to the patient. So you'll go one by one in the treatment plan, and also before planning a treatment, you will refer the patient to the physician, then only you can go for the treatment. During acute phase of leukemia, patient should receive only emergency periodontal care. If the leukemia is of acute phase, means it is of short duration. So patient should be receiving only emergency periodontal care. So if there is a persistent gingival bleeding, you can clean the area with 3% hydrogen peroxide. Carefully explore the area and remove any etiological factors if present. Re-cleanse it with 3% H2O2. Place the cotton pellet soaked in thrombin against bleeding point and cover it with a gauze. If oozing persists after removal of gauze, replace cotton and then place a periodontal dressing over the area for 24 hours. Coming to the granulomatous diseases, Wegener's granulomatosis etiology is mainly unknown, can be immunologically mediated tissue injury. It is characterized by acute granulomatous necrotizing lesion of respiratory tract involving the orofacial region. Clinical features, it is reddish purple which bleeds easily. Histopathology involves chronic inflammatory giant cells and foci of acute inflammation, microabscess covered by a thin acanthotic epithelium. Sarcoidosis, etiology is unknown. It is also seen as red, smooth, painless enlargement. Histopathology shows discrete, non-scissating walls of epithelioid cells and multinucleated cells. And also there are foreign body type of giant cells which are present in histopathological features of sarcoidosis. Coming to neoplastic enlargement, which are mainly gingival tumors. So there are benign and malignant tumors of gingiva. What are the benign tumors of gingiva? Epulis, fibroma, papilloma, PGCG, central giant cell granuloma, leukoplakia, gingival cyst, other benign masses like nevus. Whereas in malignant tumors, you will be seeing in squamous cell carcinoma, malignant melanoma, in sarcoma, you can see in fibrosarcoma, lymphosarcoma, reticulum cell sarcoma, Kaposi sarcoma, and renal cell carcinoma. False enlargement. This is not a true enlargement, but appear as an increase in size of underlying osseous or dental tissues. So, underlying osseous lesions like enlargement of bone. If you can see any bony enlargement, so what will you think that gingiva is enlarged? No, that is not a gingival enlargement, but that is due to enlargement of bone. Bony lesions or exostosis or tori is present because of which gingiva seems enlarged. Example, Paget's disease, fibrous dysplasia, cherubism. All these are examples of false enlargement. Underlying dental tissues, like during stages of eruption, mainly primary dentition. Labial gingiva shows bulbal marginal distortion called developmental enlargement. So during eruption, this marginal distortion takes place, which is called developmental enlargement and which can be uh, assumed as false gingival enlargement. So this is not a gingival enlargement, but this is a developmental enlargement which is seen in primary dentition, and it persists until junctional epithelium has migrated from enamel to CJ. It is a physiologic, and it is also complicated by marginal inflammation. So in false enlargement, there are two conditions, either underlying osseous lesions or underlying dental tissues, because of which it appears as an increase in size of gingiva due to underlying osseous or dental tissues. So these are all the syndromes associated with gingival enlargement. Okay. So we'll be discussing a little bit about gingivectomy. What is gingivectomy? It means excision of the gingiva. So how will you do the gingivectomy? You will remove the pocket wall. There is visibility and accessibility for complete calculus removal. You'll do the proper root planing, favorable environment for gingival healing, and then restoration of physiologic gingival contour. Types of gingivectomy. It is of four types: surgical, electrosurgery, laser, and chemosurgery. Indications, in which cases you will go for gingivectomy: when there is elimination of suprabony and pseudo pockets regardless of depth, but when wall is fibrous and firm, means when there are fibers, more fibrous tissue is present. Elimination of fibrotic gingival enlargement, elimination of suprabony, periodontal or gingival abscess, when base of pocket are at the same level but the gingival margins are at different level. Create more aesthetic form. Create more aesthetic form. Create more aesthetic form in which exposure of anatomic crown has not fully occurred. Example, defective passive eruption. Contraindications, when gingivectomy cannot be performed, like if there are infrabony pockets, inadequate zone of attached gingiva, Osseous surgery is indicated. Examination of shape and morphology of wound when base of pocket is apical to the mucogingival junction. Aesthetic considerations like anterior maxilla. Patients with systemic problems leading to contraindication of surgical procedures, example, uncontrolled diabetes or blood dyscrasias. And last but not the least is patients suffering from gout taking colchicine. So these are the armamentarium which are required in gingivectomy: pocket marking forceps, gingivectomy knives, Orban periodontal knives, Bart Parker blades 12 and 15. These are the steps given in the gingivectomy. First of all, marking the depth of the suprabony pocket, then the bleeding point after marking, and then external bevel incision is given. And this is the excised tissue you can see here in the picture. A complete gingivectomy is done under local anesthesia. The surgical site is covered with a periodontal dressing. Healing after gingival surgery, healing after surgical gingivectomy. Initial response, there is a blood clot formation, underlying tissue is inflamed and necrotic, and it will be replaced by granulation tissue. After 24 hours, what will you see? There are mainly angioblast and epithelial cells are seen at the margins of the wound, which start migrating over the granulation tissue. 3 days later, after 3 days, what will you see? There are young fibroblasts which are formed, highly vascular granulation tissue which grows coronally, creating free gingival margin and sulcus. And in complete 2 weeks, capillaries from vessels of PDL migrate into connective tissue and connect with gingival margins. After 5 to 14 days, surface epithelialization is generally complete, and complete repair takes about 1 month. So this is about healing after surgical gingivectomy. Coming to the conclusion part, the treatment of gingival enlargement depends on the type of clinical enlargement encountered. The enlargement can be inflammatory, fibrotic, or a combination of both. If it is inflammatory, you can see plaque will be the main etiological factor. If it is fibrotic, you can ask the patient if is having any medical history like drug-induced gingival enlargement are mainly of fibrotic in nature. So in that case, you can go for the scaling and root planing, and also you can go for the surgical removal of gingival overgrowth. Plaque-induced inflammation appears to be general stimulating effect regardless of mechanism of gingival enlargement. In recent years, flap surgery have been used more often to treat gingival enlargement than gingivectomy. So this is all about gingival enlargement and gingivectomy. References are from Clinical Periodontology and Implant Dentistry, Carranza, Outline of Periodontics, J.D. Manson, then Essentials of Periodontology, Glickman, Hallman. So all these are the references through which gingival enlargement and gingivectomy topic is covered. Thank you.